Welcome everyone to one of our BJJ podcasts for the month of August. I am Andrew Duckworth and a warm welcome from your team here at the Bone and Joint Journal. As always, we'd like to start by thanking all of you for your continued comments and support, as well as a big thanks to our many authors and colleagues who've taken part so far. For the study we are discussing today, as you know, the next 15 to 20 minutes or so will cover a range of aspects for the chosen work, emphasising the important points of how the study's been put together, as well as the key findings from the data and how these potentially fit into each of your day-to-day clinical practices. We also hope to give you a behind-the-scenes insight into how the authors have come about the study and developed the study, and give them an opportunity to put forward the key findings of their work. So today I have the pleasure of being joined firstly by Mr. Nick Johnson, who is a consultant hand surgeon at the Portaff Hand Centre in Derby, and an honorary senior lecturer in the University of Leicester. Welcome, Nick. It's great to have you back with us today.
Thank you very much.
Nick is joined by his co-author, who really needs no introduction. It's Professor Joe Dias, who is the Professor of Orthopaedic Surgery in Leicester, and who is a real Goliath in the area of scaphoid fracture research, which we're discussing today, amongst other things. Joe, it's great to have you back with us today. I really appreciate the time.
Thanks for asking me, Andy.
Nick and Joe are here to discuss their study entitled The 1-Year Outcome of Surgery Compared with Immobilization in a Cast for Adults with an Undisplaced or Mini-Displaced Scaphoid Fracture, a meta-analysis of randomized controlled trials, which has been published in the August edition of the BJJ. And the aim of this study was to conduct a meta-analysis to evaluate up-to-date evidence from randomized controlled trials in order to compare the effectiveness of the two treatment strategies for undisplaced fractures or mini-displaced fractures, which is 2 millimeters displacement or less. So Nick, maybe you could start up and give us a brief introduction to the study and also maybe some background to some of the current literature in the area, maybe some of the RCTs that we're going to be included in the study.
Thanks, Andy. Yeah, so as you just mentioned, we wanted to conduct an up-to-date evaluation of the evidence. As I'm sure everybody knows, there's been lots of papers comparing operative and non-operative fixated treatment of scaphoid fractures with varying results, but also the SWIFT study has recently come out, which is the largest, the best RCT in this field. So we wanted to look at that evidence all together and see how that changed things. As I mentioned previously, there had been quite a lot of work looking at the subject, and we had 7 randomized controlled trials that we identified and included in our study. Most of them, they were quite small and the results were varied and the quality varied as well. So, we wanted to look at that in more detail with the added robust evidence from SWIFT. There's at least 4 systematic reviews and meta-analyses looking at the subject. And again, as the evidence before was fairly poor, most of the conclusions were it's difficult to give a strong answer really because of the quality of that evidence. Some studies had suggested some better functional outcome. Others couldn't establish any difference, while some had said there's faster recovery with surgical treatment. So yeah, we wanted to reevaluate the evidence in the context of SWIFT.
Yeah, I think that's a nice overview of what they all showed up until maybe SWIFT, and like you say, SWIFT is so much bigger than the other studies that are out there. And Joe, that maybe is a good time for me to come to you and say, obviously the SWIFT trial was published in the Lancet, I think it was a year or so ago now, and although I'm sure many of our listeners will be already aware of its findings and what it says, would you mind just maybe giving a brief synopsis of what SWIFT showed and what it found, and some maybe important caveats about how they were treated in both arms?
The SWIFT study is an NIHR study in the UK, and we compared the management of acute bicortical clear scaphoid fractures, including all fractures displaced less than 2 millimeters. And we randomized them into either having surgical fixation of the fracture, and 219 were allocated to this group, and 220 were allocated to have a cast. It was predominantly a below elbow cast without the thumb included. I think that's pretty important for that. But that pathway of the non-operative pathway was not just using a cast. It was the care pathway, which is you continue to look after them. And at 6 weeks, if there was any concern about the state of union, that was confirmed on a CT. And if a non-union was confirmed, then those patients were offered surgery straight away. So those were the 2 groups that we had, and we reported on the 1-year results. And the main summary findings were that for pain and function, there was no difference between the 2. For return to work, those that were fixed with a screw returned to work at around 17 days after their surgery, compared to 18 days if they were treated in a cast, which meant that a large proportion of those that were treated in a cast returned to work when still in a cast. And that was the advice. And the healing, the union rate was only a 2% difference.
Yeah.
No, it was 96% compared to 98%. The complications between the two groups was different. So significant complications that left an aftermath of stiffness, of nerve numbness or something like that. It was about 12% after surgery compared to 2% on the non-operative. We also did the cost effectiveness and qualitative work, but I think this is the important bit.
Yeah.
In which we define.
No, absolutely, Joe. That's an amazing synopsis. And I think, like you say, highlighting that early intervention, the non-operative arm, if they're going on to a non-union, is really key. And I think, like you say, with the return to work, that is certainly something which I thought was interesting compared to some of the previous studies which have really advocated that early return to work. But obviously, Swift didn't show that. I mean, I think that's a really important finding, isn't it? So if we move on to the study design, guys, this was a prospectively registered systematic review with meta-analysis that was carried out according to the PRISMA guidelines. So, Nick, if you could maybe just give us a brief overview of the inclusion criteria for the studies, which ones were included and which were not.
Yeah, so we only included randomized controlled trials in adults, and similar to the SWIFT trial, we were comparing surgical fixation of any sort. So it could be percutaneous, open, retrograde, antegrade, with non-operative treatment in a cast, but with early fixation. And the type of fractures were scaphoid fractures with less than or equal to 2 millimeters displacement.
Yeah, absolutely. And it was the RCTs that you were looking at, wasn't it? That's right. And in terms of the primary outcomes you looked at, what were those? And I suppose any sort of any secondary outcomes that you could look at with the data you had?
Yeah, the primary outcome was functional outcome at 12 months. So on a patient-rated outcome measure, and we use reverse scoring if necessary, change the polarity to give that as a percentage so we could compare different scoring methods.
Yeah.
Secondary data that we looked at grip strength, range of motion, complications, and non-union.
Yeah, absolutely. And I think that the non-union one we can obviously come on to about how that was looked at. But in terms of the sort of analyses, you sort of did a variety of analyses there, all that you see in the meta-analysis, random versus missed effects. But just give us a brief overview of what you did and why, Nick.
Yeah, well, initially and in the protocol, we planned to do a fixed effects analysis. But of course, when we were looking at the data, there's quite a lot of clinical heterogeneity, in the surgical approach, the type of fracture, the pattern of the fracture. So we were concerned that there was heterogeneity, so maybe random effects is more appropriate.
Yeah.
So in the end, what we did both and presented both. And it was quite interesting. There was hardly any difference at all between them. It was just one outcome at one time point that had a difference.
Yeah, I thought that was interesting as well, Nick, actually. But I think it was quite nice the way you've presented them both in the study and the comparative. It's very clear with the forest plots. It's a nice thing to see, and I encourage our listeners to go and see those. So if we move on to the results, like you say, there were eventually 7 RCTs. There were over 360 studies screened, full text 15, and then you got down to 7 RCTs, and with sample sizes ranging from 25 to obviously Swift, which was 439, and the mean age of the patients was 30 years, and 83% were male, which is very consistent with the scaphoid fractures we all see. And Nick, so what did you find in terms of, firstly, the quality of the studies included in the analysis?
Yeah, I think the first thing to say is we assess risk of bias using the Cochrane tool and quality using the grade method. And what we did was there was myself and another co-author, Ewan Sterling, who's a trainee in Oxford. Neither of us were part of the Swift team. So we analysed that data. So we were completely separate because all the other co-authors are part of the Swift team. Yeah. And what we found was, well, there were 7 studies included, 3 were high quality, 4 were low quality. As I mentioned before, a lot of the older RCTs are quite small numbers. Yeah. And we did find the Clementson paper, we thought had some bias in it, because what they did was they scoped all the patients initially who were having surgery, and they took out those with a scapholunate ligament injury. So that scored as a potential high bias. No, absolutely. And I think, like the saying, table 1, it's very clearly laid out, particularly looking at risk of bias for function and union, which are the key outcomes. And that sort of leads on to what you found. So what did you find in terms of the primary outcome, which was like the patient-reported outcome, really, or function at 12 months? Yeah, so at 12 months, there was no difference between operative or non-operative fixation. There was some heterogeneity in that analysis, but the results were exactly the same for the fixed and random effects, and it was actually the same at 6 months as well.
Yeah, absolutely. And in terms of the secondary outcomes, things like pain, range of movement, grip strength, and maybe if we focus a bit on complications and non-union, what did you see there?
Yeah, so pain was no difference at either time point. Range of motion and grip actually did have a significant difference at 6 months, but not at 12 months. But when you actually look at how much the difference was, it was a really small effect size.
Yeah.
So it wasn't much at all. I think it was 5% and 6%,
Yeah.
something like that. So whether that's clinically significant, potentially not. The other thing to think about is this: the 6 months time point. We actually had some studies that we included that the data was collected actually quite a bit earlier than that, 16 weeks. So we grouped it. It was the nearest time point around 6 months. So there would be some patients that really hadn't been out of a cast for very long at all. So that may have influenced those results.
Yeah.
Non-union, the early non-union did favor surgical fixation, but again, it was very small difference. And at 12 months following the pathway of fixing them, if there are concerns about union, there was no difference.
Absolutely, yeah. No, I think that's right. And like you say, with those differences you do see with maybe the secondary outcomes, they maybe are a significant difference, but actually whether they're clinically significant is probably very, very doubtful. I agree. So if we sort of put all that into context, that's a really nice overview of the results of the study, and I think very, really clear. And it's the strengths of the work is really clear to me. Prospective setup, very sound analysis performed. It uses the latest evidence and robust methodology to really provide some very useful information, I think, and draw all that data together that we have out there. And, the study has found no difference at 1 year in functional outcome for these undisplaced or misplaced scaphoid waist fractures, and we should emphasise they are waist fractures that the study's looked at, and whether they're treated with surgery or not, with a complication rate that obviously would be higher, slightly higher in surgery. And I think very importantly also is to highlight sort of that although the rate of non-union was higher after normative treatment, it actually has a very low risk overall of occurring at 1 year. So, Joe, if I came back to you, what do you feel are the key messages? Was there anything that surprised you about the data? And I suppose, what do you feel the limitations of the data are out there despite all?
I think that overall, the messages are consistent. There have been a large number of systematic reviews of the same number of studies. And they all come with slightly different flavors, depending upon how you extract the data. So we were very meticulous. We mitigated all the biases by having independent reviewers and all that. But like all systematic reviews, particularly in our specialty, trauma and orthopedics, we are dependent upon very low numbers. And therefore, becoming meticulous in how we do it is an important way of doing it. But we need to recognize that there is a whole number of limitations. In this systematic review, there is a problem. And the problem is that we are synthesizing data where patients were recruited in the 1990s.
Yeah.
30 years span. And the way we address and advise patients in that time has changed. I'll give you one example. The casts that we used for the non-operative arm were hugely different. One of the studies used an above elbow cast with the thumb included, and that is hugely disabling.
Yeah.
Even a scaphoid cast is disabling. So the different casts that were used change the impact on the patient, and therefore would translate to different functional outcomes, particularly at the early time points. The other thing that was a limitation in all this is the ways that we identify union or non-union, because most of the studies, apart from Clemenson and the SWIFT study, identified the state of union on X-rays.
Yeah.
And we know that radiographs are less good than CT. So again, trying to synthesize data from radiographic assessment of union versus CT assessment of union, it creates a lot of variation. The advice that we give our patients is completely, now the advice is use your hand as much as possible, avoid wrist movement, because it's wrist movement that will cause mobility of the fracture. All that has changed, and all those create limitations in how we synthesize data. The other thing about most of these studies that we synthesize is that they do not tell us what happens in the long term.
Yeah.
So the long-term consequences, particularly with regard to arthritis or penetration or function or the impacts of injury, and we don't know any of those. And the really important difference, some of them, like the green paper, use different definitions of return to work that some of the others use. So therefore came up with huge impacts
Yeah.
they were reporting compared to the Swift study, which was just a day difference.
Yeah.
And I think all those need to be borne in mind that at the end of the day, this synthesis involves also imputation and adjustment of data in order to put it all together. And I think all those are limitations of synthesizing data.
Yeah, no, absolutely, Jen. That's a really nice way to put that all into context. And actually, I think appreciating that change, like you say, it's over a 30+ year period, and how our practice has changed, particularly in the non-octave side, like you say, and the ability to get back to work if your thumb is immobilized is very different than if it's not, as you say. Nick, if I just maybe come back to you briefly, in terms of how you feel these findings fit with the current literature, is there anything you would want to add to that at all?
I mean, I think you've both mentioned it just now, really. I think this is a robust study which just adds and confirms to the current literature, mainly Swift, really. I think it's pretty clear from Swift and now this that there's no functional difference in outcome at 12 months, and complication rates, serious complication rate is higher with surgery, which is what we'd expect.
No, absolutely. And Joe, if I could come back to you with, you mentioned about the non-union data. Is that sort of what you would recommend now? Is that if you are going along that, I suppose any arm, but the non-octave arm in particular, if you reach that 6-week point and you have any concerns, straight to a CT scan to confirm union and intervene early. Is that what you would recommend?
Absolutely. If you've got any doubt about the state of union, and the doubt could just be there's a faint lucency across,
Yeah.
then just resolve that doubt.
Yeah.
And that was the failing of some of our earlier studies, where we classified as a non-union, which subsequently proved to be a partial union.
Yeah.
And the studies that were in the first decade of the 2000s used that. So we don't know whether they were reporting partial union or non-union.
Non-union, absolutely.
So, but the recommendation is very clear. You resolve the doubt, and they fall into just two groups. It is joining, in which case you continue to protect the wrist but restore function, or it is not joining, in which case you go and you fix it.
You intervene, yeah, absolutely.
Hitting at less than 10% of all the cases.
Absolutely. And maybe just to finish off, I'll maybe ask you both the question, maybe slightly controversial. So do you offer percutaneous fixation now? I'll maybe go to you, Joe, first. Do you offer percutaneous fixation to any patients acutely now?
I think fixation is a tool in our armory as trauma surgeons. And when we are faced with a situation where fixation will give us an important and clearly identified benefit, then we do fix. So it isn't about not fixing.
Yeah.
It is about using the tools that we have. Let's just give you 3 examples where we could consider immediate day one decide that fixation is appropriate. All these examples are uncommon. So the first is if you've got a scaphoid perilunate dislocation, and there's a completely unstable proximal carpal row, then fixing it changes stability early. And there is a clear identified benefit. The second is a sort of a relative indication is when there are multiple associated fractures. For instance, a shattered, shortened distal radius fracture that you're fixing, and you also have a scaphoid fracture. Then fixing the scaphoid fracture there would make complete sense. You're there in any case. And the risks that you're exposing the patient to, the patient is being exposed to in any event. So, and it becomes logical. And then the third group is fractures that are displaced over 2 millimeters. There's no evidence that you fix them or you don't fix them, but the logic would dictate that these are going to be displaced and more unstable injuries. And although they account for only around 4 to 5%, the full proportion of acute scaphoid fractures, that would be the other group that you might consider whether or not to fix, and have a more detailed conversation with the patient.
With the patient, yeah. That's a really nice way to think about those three categories. Anything you'd add to that at all, Nick, in terms of your practice?
But they still couldn't, use their wrist for heavy activities or anything because the bone's not healed.
And how if you've changed at all?
Apart from those three mentioned would be if there was somebody who just absolutely was not allowed to work with a cast on, if they just had to not be wearing a cast and they understood the risks and were happy to take that risk of higher complications, then possibly. But from the literature recently, that seems to be a very rare scenario nowadays.
No, I agree. I suppose the only potential scenario is one more scenario is an orthopedic surgeon who can't screw, but that's a controversial one. But anyway, no, guys, thank you so much. That was absolutely brilliant, and it was really great for you both to take the time to join us. And congratulations on another outstanding study in this area. And I think without doubt adds substantially to the literature. And it was great to have you both with us. And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through social media and like. Feel free to tweet or post about anything we've just heard today. And thanks again for joining us. Take care, everyone.